Hey, good afternoon and welcome everyone. I'm Jasmine Arazi, Program Manager here at IPFCC, and I'm joined by my colleague Marie Abraham, Vice President of Programming and Publications. Providing expert technical support today is our colleague Matt De Silva. And we are all very excited to have our guest speaker, Dr. Barbara Lewis, founder of Jones Family Bill of Rights, joining us today. Congratulations to her. She just defended her dissertation. We're very excited. Today's discussion is on evaluating the impact of patient and family advisor partner programs. We are very excited to see how many of you are here. And it's obviously a topic of significant interest. As you come in, please feel free to chat in your name, organization, and where you are joining us from. We are recording this conversation so that we can share it with others who are registered for the recording and post it to our website. While we like seeing faces, if you prefer, you can go off camera. Next slide, please. We want to take a moment and acknowledge our PFCC Connect sponsors. Special thank you to Emory Healthcare, Providence Healthcare, and University Health for your continued support. Thank you. Next slide. And as you know, our conversations are intended to be interactive and informative. We will share a few slides to set context and to provide information to get the conversation started. But then we'll dive right into the discussion. We just want to remind everyone of our group agreements. Be as present as possible when we move into our discussion. It would be great if you could go on video. Participate actively. We encourage you to be curious and ask questions, but also share your experiences, perspectives, and any challenges you have faced. You can either chat in your questions or ideas or raise your hand to be called on. And let's share this space, allow others to contribute to the conversation as well. Embrace a learning and growth mindset. All of you bring expertise and we have a lot to learn from each other. And finally, we hope you enjoy the discussion and have fun. If at any moment you experience technical issues, you may chat Matt De Silva directly.
Thank you. And thank you, Jasmine. So in the registration form, many of you filled out some of the things that you're most interested in hearing about today. And I want to thank everyone for sharing that information with us. And here's what we heard from you about what you all want to hear more information about. So are there frameworks to use for evaluation? And are there resources and tools that others can share that have been used that that everybody can access? What metrics should be used to measure effectiveness of engagement? And how to collect data that shows the cost benefits of PFA contributions. I think that's a big one. And then finally, we know many of you have experienced the impact of the pandemic and leadership turnover, and it can be quite challenging to get the buy-in from leadership. Next slide. So why is evaluation important? There's lots of reasons. I would say that one reason is we don't have a lot of information on this, although we did bring in an expert that is going to help us think through this. So here's just a few slides. The first one is a quote from Barbara, one of her articles that she's written about this. And you can just, I'm not going to read these out loud. You can just look at what's bolded to see the importance of it. So, PFACs need to implement metrics with all the projects which they undertake. That's so important. Rigorous evaluation of programs is needed to support the expansion of system-level patient engagement. Again, extremely important. Next slide. And then we know there's only a small amount of research, as I mentioned before, but there is some research. And so these two different researchers, as a matter of fact, have given us some information. And so in one study, the Merner study, they showed that health providers and consumers perceived positive impacts. And you can see person-centered culture, built environment, design, and delivery of services. So that's really important. And then the Anderson et al. Study, they found that our study confirmed these impacts in the hospital context and revealed several other impacts. So I think that's really important. If you want to chat in why you think this is an important topic and what brought you here today, that's fine with us. We have two people, Pam Dardis and Jasmine, who will be looking at the chat or help moderating the chat. And I'm going to hand it over quickly to Barbara.
Thank you so much, Marie, and thank you, Jasmine, for that introduction. Next slide. Here's what we're going to cover today. What does the data say? I'm going to talk about over 200 journal articles that I've read for my dissertation, and then we're going to get to PFAC evaluation. Next. So this is a little bit about my background. Jasmine, thank you for calling me doctor, but I'm not quite there yet. My defense yesterday was for the prospectus of what I'm going to do. So that's why I have a C after PhD, because it means now I've advanced from student to candidate. And my dissertation is on patient and family advisory councils. So I've done quite a bit of research, and I've actually been researching this for the past 10 years. Next slide. So I originally got a grant from the Barrel Institute to build the business case for why we should have patient and family advisory councils. That was about 10 years ago. And you can Google this, PFACs, where's the money, the financial impact of hospitals. And what I proved was that PFACs save hospitals money, they improve safety, and they enhance the patient experience. But in the research that I did 10 years ago, I found that there were 3 hospitals that closed their PFACs. And I went crazy because I thought, I want more PFACs in every hospital. And here are 3 hospitals that closed. So I asked the question, why? I connected with each of those hospitals, and here's what they told me. Next. There were new CEOs. So I was trying to figure out what it is about new CEOs that forced them to close their PFACs. And what I decided was that probably these CEOs came on board and they said, what is a PFAC and what does it do? And there were no metrics, there was no proof of value, there were no annual reports talking about the great accomplishments, and the CEO just said, no, we don't need this. Next. So during my dissertation research that I'm doing, I went to the American Hospital Association, which does an annual survey of 61 hospitals in the US. There's 1,300 data points. And since 2018, they have asked this question: does your hospital have an established PFAC that meets regularly to actively engage the perspectives of the patients and the families? So let me show you some results of research. Next. So here's the 2018 and 19, here are the years, the total hospitals, the number that answered, the percentage that answered, and here's the number of PFACs and the percentage. So we were at the top in 2019 of 55%. However, then we hit the pandemic, and in my calculation, there were about 200 PFACs that were eliminated. And now we have just creeped up the latest data in 2022 to 53% of hospitals have PFACs. Next. So here they are by state. And if you look, you can find your state here with the percentage of hospitals that responded that have PFACs. The dark have 100 up to 100%, and the very light is 13%. Next slide. So in the US, as I mentioned, total 43. In Idaho, the lowest is 13%. In Massachusetts, which has mandated PFACs, has 100%. And then next door in Connecticut, 95% of all hospitals who responded to the survey have PFACs.
Connecticut.
Next slide. So the 200 plus articles that I have reviewed over the past year that I've been working on my dissertation, you can see that before 1980, there were very few articles written. And in my research, I found that the first PFAC was established in the early 1980s in Massachusetts in a children's hospital, actually. And then you can see as we go up, even in the first 2 months of 2024, and since 2020, 81 articles have been written. And that's about 40% of all articles on patient family advisory councils. So what I did is I looked for patient family advisory council, PFAC, patient advisory council, either in the title or in the abstract, because I found if it was mentioned in the content, it was just kind of a cursory mention. So these are articles that are listed with PFAC in the title or the abstract. Next. So the article review revealed 3 things. What I was looking for is how are PFACs interacting with the hospitals? Are they just approving an initiative? And oftentimes the article said, we brought this to the PFAC for their approval. So that was listed, and 4 articles mentioned that. Then did they provide feedback? And again, the article mentioned we wanted to get the feedback from the PFAC. That were 14 articles in that category. And then finally, the gold standard is really co-design. And this is something that Kaiser Permanente is doing, and actually sent me to a workshop with their employees to learn about co-design. And there were 10 articles on co-design. And this is where the patient is involved from the ground floor of helping the organization with the initiative. Next slide. So very few of these over 200 articles had anything to do with metrics. And this was really disappointing to me because, again, I know the history of PFACs being eliminated with new CEOs who come in and say, what's the value, and can't find any. So these are some of the projects that had metrics. Next slide. So in Massachusetts, which has mandated PFACs, part of the law is that you have to provide for any public person who asks an annual report. And these annual reports have been collected by Healthcare for All and put on their website. And now that's been taken over by the Betsy Lehman Center. But twice in 10 years ago, and then more recently, a couple years ago, I went to the website and read every single one of the reports from the hospitals. And not one of them had outcome metrics. So here are the 3 types of metrics as defined by AHRQ. So there's process metrics. And this is what every hospital annual report had. We met 12 times. We have 15 people. We looked at 14 projects. We attended this kind of training. There were a couple of structure, which is capacity, for example, reducing wait times, but there were no outcome metrics. And this is really sad that hospitals are not measuring in general. There were 2 reports that said, we need to start measuring. So measurement, for example, is a pre and post metric. For example, procedure cancellations decreased by 50% after PFAC revised the directions. So one of the things that I'm saying to get buy-in from leaders is recommending that everyone create an annual report for their executives on their accomplishments and then distribute it widely, not just to the leaders, but to all departments and everyone, because 2 things happens. One is you get departments saying, oh, look what this department did when they went there. We should go with this initiative. So then you'll have a queue of departments waiting to talk to the PFAC as kind of a focus group. And the other thing, of course, is that leaders won't be eliminating PFACs because they'll see the value. You can tie it to money too, and we're going to get into that in just a second. Next slide. Okay, so here are the steps for measurement. So the first thing that you have to do when you want to measure is, what are you going to measure? You have to define that and then establish the parameters. Are we measuring in this kind of time frame? Are we measuring these kind of patients? You know, what are we measuring, and get those parameters down? Then establish the metric. Are you observing what's happening? Or are you going to the electronic health records and gathering data there? Or, you know, what type of metric are you going to be using? Then you're going to gather the data and then measure the baseline. So you'll always need a before and an after. And this was a problem with almost 200 of the articles that I read, is that there was never a baseline. There was never a before measurement. So of course they couldn't measure the result of what their impact was because they didn't have the before. Then you want to analyze the data, of course, and create a compelling story. So for example, if you're talking about falls, you can talk about what the situation is and why people are falling, for example. And in an example I have, which is quite interesting, is that people were falling more when their family members were around, which they couldn't figure out why, but then they thought, oh, the family members are there and the sick person or the patient is saying, no, I don't need any help, I'll do it myself. And then they fall down. So you're creating a compelling story as to why you're doing this, why you're measuring, so the department is on board with this and partnering with you. Then you're going to do the intervention of whatever it is, and in that falls, it was no one walks alone, and the patient with the family members say, no, I'm sorry, you can't, I need to ask somebody to help me because this is the mandate in the hospital, no one walks alone. And then you're going to repeat the measurement after the intervention. Next slide. Okay, so how much data do you remember? Well, it depends. I'm sorry, just go through the whole slide, Matt. Yeah. I'm sorry, I thought I had taken off the layers here. I did not. Okay, so you can pick a time of 1 month or 3 years, for example. Hopefully it won't be 3 years because you don't want to wait that long, but you need a certain number of data points. So if something's happening once a week, well, 1 month is not going to do it. You'd probably have to do at least 3 months to have 12 data points, or 4 months. You want to make sure that you have a statistical sample, and there are now algorithms and formulas and websites where you can put in the total number of patients that you have, for example, and how many you need to have a statistical sample, and it'll just spit it out to you. And of course, you want enough data to prove your case. Next slide. Okay, how do you measure? Well, there's a lot of different ways that you can measure. You can measure with surveys, with electronic data from the health records. You can measure across time. You can measure the amount, the cost. You can observe, or the number of. So let's say with falls, all right, they may have reduced falls X% because no one walks alone in that particular example, but what does that equate to money? Well, and literature shows that an average fall costs the hospital $5,000 a few years ago when I did this research. So you can say, okay, we saved the hospital X amount of dollars because we reduced the number of falls. Next slide. So here's the different ways that you can display the data. You can do a run chart over time, a bar or line graph, a thermometer, a pie chart, a scattergram, and the data display should tell the story. And it's much easier to see this story than it would be if I talked to each of these points. Next slide. Okay, what if there's not quantitative? You don't have numbers that you can mention to measure. So you can get you can survey the department for qualitative data. You know, what were the top 3 most meaningful pieces of information? Suggestions for improvement in your PFAC encounter. Next slide. And here's an example. So this is both quantitative with the numbers and qualitative with the 3 questions afterwards. So now you're getting both. The meeting planning, the logistics, the meeting discussion, you know, 1 to 5, with 5 is excellent and 1 is poor, and then asking questions. In a few words, how would you describe? And here's an example. Our project changed 180 degrees when we received PFAC feedback. Next slide. So here are my recommendations. I'm sorry, go ahead and go through this and stop. Okay, so you can measure every project. You know, I've rarely been able to find projects where there is no measurement involved. Log the results, and of course, write that annual report for everybody to know. Next slide. So here's the article that was mentioned initially, and I can put this link into the chat. And let me just, you know what, I'll do that afterwards. Next slide, because I know I'm running out of time here. Okay, so here's my email address, and it would be great if you could participate in a survey that I'm doing for my dissertation, because I am going to be going out to hospitals and asking them certain questions. And I'm hoping that many of you can respond to this, to the questions. And I'm just going to send it out to everyone. There we go. You don't have to answer the survey if you don't want to. It's going to be a survey across the US of as many PFACs as I can get on certain items. And all I need is your email address, which I'll have, and your first and last name. And then I will send you the survey. And thank you. Thank you. Thank you. I really appreciate it. I put my email in the chat. Next slide. Okay. Marie.
Yes,
I'll
thank
hand
you,
it over to
Barbara.
you. I think I went on.
That was a lot of great information. Thank you. And the chat's been quite busy. So Pam and Jasmine, I haven't had time to look at everything, but I'm wondering if something comes up. And I see we have some people who have also done similar work to Barbara's work. Nadine, I don't know if you want to come on and let us hear a little information from you. And Matt, you can take down the slides now since we're into discussion mode. Thanks.
Hello.
Great, thank you. Nadine, can you come on? Because I saw that you did a dissertation in this area as well.
Yes. Hi. Can you hear me, Ron?
Yes.
Yes. I had the fortunate opportunity of doing my study last year with the Northwell Health System, which happens to be the largest system in the New York State. And so my focus was, trying to get the perspectives of healthcare leaders within the system about the value and the influence of patient and family advisors. And it was a qualitative case study. And so I had the opportunity to do a focus group, one-on-one interviews, and also review documents that were submitted by these leaders. And we're talking about lower level, mid, and upper level leadership. And there were just three overarching themes, basically, where healthcare leaders felt that patient and family advisors provided highly valuable input in hospital operations, because this was the acute hospital care setting. They also felt that there was value in the fact that their views were different from those of the employees. And I also found that within the Northwell system, these patient and family advisors were involved in a broad scope of activities. So that was just really good to see, to get the perspective of healthcare leaders, because we know that they are essentially the gatekeepers as to whether or not, a PFAC is implemented, or how, the institution or the organization feel about patient and family advisors and engagement and patient and family centered care. So it was really good to have, it's straight from the healthcare leaders. Thank you.
Thank you, Nadine. Great work.
Sure. Thank you.
Marie, there's a question from Lindsay that I think would be helpful to read out loud. It says, what's your opinion on surveying patient and family advisors involved in the PFAC? How much is too much? And is there a recommended limit as to not overwhelm them?
I'd like to hear from people in the group to see what your experience has been in doing that and how to keep it from being overly burdensome.
I don't know. Can you hear me? Okay.
Yes, Tara. Mm-hmm.
Hi, my name's Tara. I'm actually from the Northwell Health System. Our PFAC, our PFAC never dismantled with COVID. We were able to keep our PFAC and actually add members on throughout, even during COVID. But what I have seen is there's such a robust need for their feedback in many different areas of the hospital. So our strategy has been, we've been developing some specific PFACs in addition to the central overarching PFAC for the hospital. So for an example, we have an emergency department specific PFAC. So because there's so many pieces and areas of opportunity for patient advisors in our emergency department, emergency services, that we felt instead of kind of overburdening the overarching PFAC, that having these sub PFACs that then kind of work with the leaders of the emergency department and have executive co-chairing on that has been helpful. And we're implementing that same strategy in our OB mother baby program as well, to have a specific PFAC for that area. And so that's just a strategy that we've taken because it does become burdensome for the patient and family advisors. They want to be helpful and they're really purpose driven, and that part is great, but the ask sometimes just becomes too much. And so being able to, as myself as a leader, kind of seeing how there's opportunities to break things up so that people can be part of something, but they don't have to be kind of involved in everything has been my strategy. I don't know if that will work long term, but it's the strategy that we've been going with. And it so far has been successful.
Thank you, Tara. Yeah, and we had a question, I just want to address it, about the definition of PFACs. IPFCC has done 2 studies, one in the state of New York, and in hospitals in the state of New York with PFACs, and one, Pam, you might want to talk about it, in children's hospitals. And I see we have 2 people's hands up too, so I want to get to you all. And both of those studies kind of they outline what important factors are significant for PFACs. So they don't it doesn't come up with a clear definition. What we like to say is an active PFAC shows that they meet more than 10 times or 10 or more times a year. If they're meeting 3 or 4 times a year, that's not really a PFAC. That's more like a feedback group or something. Okay, so let's move on to Jonathan. Good to see you.
It's great to see you, Marie, and folks here. So regarding surveys, I think one of the things that the pandemic gave us one of the things the pandemic gave us was this ability to connect with our patient partners at Kaiser Permanente in a different way. And I lead PFCC for Kaiser Permanente, and super lucky and really privileged to have this role. And so we didn't close. I think the vast majority of our patient advisory councils continued to meet during the pandemic. And we begin to engage in different ways with them, right? So we begin to send out surveys to our network, and we have a little over 1,300 patient partners. And we begin to send out surveys to them, just asking for their input on various projects that were still underway during the pandemic. And what we found was this really great desire to be involved. We've continued to do that. We've made some changes, right? So we're not surveying folks all the time outside of the advisory council structure, but we're looking at like a couple of times a month where we're pushing out asks that come for various projects across the organization with surveys, and we're getting between 30 and 40% response rates where people get to self-select in. And it's just, I will say it's made a huge difference because of the reports that we're able to put out. And we use this, I think, as a way to augment, but we have found that you can over survey. So we don't send out more than a couple a month, plus whatever's happening within the local advisory councils. And we have, I think, about 95 advisory councils right now. Surveys are really good, but it's not something that you want to take the place of your advisory councils. And you don't, I mean, for us, we're looking at no more than about 2 a month.
Thanks, Jonathan. That was super informative. And Fran, you've been
Hi,
waiting patiently.
I'm in Michigan, U of M Health, Sparrow, and Lansing. And we had not been surveying our PFAC. Last year, we started just a basic, what seemed to work well in our meeting, what would enhance the efficiency and effectiveness of our work in the future. And we got some fairly good response rates. And then they said, we're not going to do this. Well, they didn't quite say it. They said, we want to know what you're going to do with the feedback we've given you. So the expectation became that prior to the next meeting, we would summarize, okay, you asked about this, this is what we're doing in response. And now we're finishing our first annual report on that. And we've been asked to say, okay, what is the status of what you committed to do? Where is it? And if you're not there, you know, what's delaying it? So it's a low level of accountability, but it's more than what we had.
Yeah, and that speaks to follow through, right? That PFACs really want to have. They want to see have they made a difference or not, right?
Yep.
Okay. What else? Jasmine, are there other questions in there or that we should, or are there questions for Barbara as well?
I believe Dana wanted to share, it was a tool that they used to evaluate.
So Dana, do you want to come?
Yeah. I just wanted to mention that we've been using this tool that was developed by colleagues at McMaster University, and it's been super helpful. The tool is basically there's 3 different types of evaluations in this survey tool. One where you can evaluate the impact of a particular project you've conducted with patient partners. And then one that's a little bit more organizational, which is the one we've been using when surveying our PFAC members and colleagues to kind of look at impact. And I've been finding it to be great. We've been doing it once every 6 months and then kind of using that as a measure. I also saw a few other people in the chat that said they're using the tool. I believe Stuart was one of them as well. But it's a great tool, and I put the link to the tool and you can download it. It's free.
Oh, that's great. And you did, can you put the link in again? Because this chat is so busy. It'd be great to see the link again. And Aiden, I loved your comment on what the PFACs kind of held you to the fire a little bit there. Is that right? Did you want to comment on that?
Yeah, very much so. I think we found ourselves, they had just come out of what we considered a really successful project. They helped us map and generate a report called the Ideal Care Experience from the patient family perspective. And so we celebrated that. It was a fantastic guide and we're using it in our strategic planning. And then at the end of the year, when we were doing evaluation of them, they were like, that's great, but we want to improve the day-to-day impact, like the care that's being delivered. And so then we actually ended up regrouping with them. We went to our senior leaders in child and youth mental health, which we happen to have a dyadic leader. So we have ops and medical together. And now they regularly come to the PFAC. They've jointly, between the PFAC members and leadership, chosen a priority project. Right now we're looking at security involvement in mental health care. And that's their sole focus. So we're not getting distracted by strategy and sort of falling into that trap of being like an informational PFAC rather than a collaborative PFAC.
Mm-hmm. Thank you. Barbara, I think earlier there was a question about the Massachusetts PFACs, and since you have probably kind of drilled down into that quite a lot, I'm wondering if you could respond to the question. I have to go all the way back to find that question, but I think it had something to do with what they're reporting.
So the report is a form that was developed, And it has 3 questions that have specifically to do with accomplishments. And I might be able to get that and put that in the chat, but in their accomplishments that they have, when they talked about it, it all had to do with process measurement. We met X amount of times, we had this many members, et cetera. We had this many departments come to us, but nothing about the results of what they did. So I can find that and put that form in the chat.
Yeah, I think is it still available on the Betsy Lehman Center? Do
Yeah,
you
so
know?
the Betsy Lehman Center has it, and also the Healthcare for All might still have it up on their website too.
Yeah,
The
I don't.
accomplishment.
Yeah, yeah. Good point. So I think that, accomplishments is one thing, outcomes is a whole different animal, right? So, and I think we've talked about this before in previous conversations, that it's great to hear about the accomplishments, but it's got more impact, especially with senior leadership, if you show the outcomes, like the example that Barbara presented with the falls, and show the impact of the advisory council efforts. Katie.
Hey, I was just gonna say, I'm in Boston. I'm in Massachusetts. I work at Boston Children's Hospital. I'm also a patient parent, so I've been involved in creating annual reports, both as an advisor and for the past 8 years as a patient, and work for the Office of Experience and do family partnerships. And I will say that we actually are at a point where we create 2 annual reports. The state of Massachusetts is all process. It's about a 16-page report. It's highly detailed, but it does not ask for black and white outcomes. And it also limits the reporting of your accomplishments to 5 of your highlights in each different areas. And so we report outcomes where possible, but we actually create a secondary report that we post to our external website in lieu of the Massachusetts state report, which is pretty cumbersome. That one is more visually appealing, and that is the one that we highlight to our staff and leadership workforce here at the hospital to promote partnership on the behalf of our family advisory groups.
Is that something you would be, you could share with us so we could post it on because I don't think we have your annual report on our website.
No, sure thing. I'd be happy to share
Great.
that.
Yeah.
Yes, I'll do that.
You
But
can
I will
just send
also
it to
say,
me.
yeah, I will also say that interestingly enough, what our families like for recruiting purposes, they're not as interested in our safety reporting outcomes. For instance, we have families on the Falls Committee, and there are absolutely positive outcome measures. But from a recruiting standpoint, which is actually why our report is externally, we tend to use testimonials from staff and leadership partners at the hospitals in lieu of some of those percentiles. It's only due to catering to the audience. That's it.
Yeah. Yeah. That's great. Stephen.
Hey, can you hear me okay?
Yep. Mm-hmm.
Awesome. I have a question for Barbara. I threw it in the chat, but the chat's popping, so it might have got lost. And this might be a bit more of a meta question. I'm curious if in your research you've come across any examples of PFACs or patient advisor programs kind of developing and utilizing proper like program logic models for evaluation. It's something that I'm kind of currently in the early days at my organization. We're kind of developing a program logic model because there hasn't been one in the past. That would kind of, for us in turn, inform what we're evaluating and why we're evaluating and the change that we're hoping to see. And so I'm just curious if you have seen any hospitals take that approach, or if anyone else has kind of gone through that rigmarole of a very in-depth kind of program evaluation approach.
That's a great idea, but no is the answer. So the over 200 articles that I read and analyzed, only 7 of them had metrics, and there was nothing like a logic model. But that is something that would be very useful and worthwhile. Thank you for doing
Appreciate it.
that.
Yeah, Stephen, I would say that we worked with Family Voices, and we've created, we haven't distributed it yet, a logic model for PFACs.
Oh, great.
Yeah, but it's not, unfortunately, it's not publishable yet, but we were hoping to do that. I'll check with Beth Dwartsky, who was working on it. She's retired from Family Voices, but she and I worked on that quite a bit. So, but that's the only one we've seen. That's why we developed it. Yeah. Good
Awesome.
question.
Thanks very much.
Yeah, sure. Okay, others.
Marie, Aiden just presented a really good question that I think we can discuss. Does anyone have either resources or links? Oh, there it goes. To help support training partners in understanding program and project evaluation so that they can participate equally.
Aiden, can you say a little bit more about that?
Yeah, we just find so our partners do work very closely to our traditional like quality improvement leaders, quality improvement committees, and even ourselves, engaging in program and project evaluation. But I always find that there's a little bit of a barrier. There's sort of all the expertise within on the traditional within the house in healthcare, and then trying to strike that balance between if we could perhaps offer the ways that we could skill them up in some areas, reduce that sense that we're like talking down in a lot of ways, or that we have to sort of like, it feels like mom and dad have to go aside, figure out all the technical stuff, and then kind of bring it back to you and be like, would you like us to do this? Or we just dumb it down a lot for them, when I think it would be so much richer if they could participate in the technical side of the conversation and really help build the plan. But knowledge does tend to be a barrier.
So I think that, so Michelle responded that they don't have resources, but courses are available for credibility in Canada that we offer to those who are interested. And I don't know, Michelle, if you want to come on and describe that a little bit before.
Hello, everyone. We do actually have, so it's not just offered to everyone, but if you've been like a PFA or involved in or interested in research, we do have courses that we offer through the university, as well as through Alberta Health Services, so that you're, certified and that you have credibility when you come to work with a research project or to work with a research team. So that is available. So that's food to think about, reaching out to like current, universities, colleges around the area to see if you can work to sort of get that available. And I could put that or send it, the ones that we have here in Alberta. But that's kind of what looking at partnering sort of with groups, because, universities want research participants, assistants, and volunteers. So those are ways in so that you can create sort of those partnerships, and then also, build into your PFAs and PFACs.
So this is Debbie. I don't know if you can hear me, but I'm in my car, so I can't raise my hand.
We
but
can
I
hear
just
you,
wanted
Debbie.
to say,
Yeah.
Okay, thank you. I just wanted to offer that I've been the engagement coordinator for patient and family stroke survivors for a couple of years under a large Macquarie funded project, the Patient Center Outcome Research Institute. And so part of my responsibility was to train up or to educate the stroke survivor and caregiver groups. And we have some healthcare professionals on there too. But to really orient them to what the research was, what their role might be, and just give them sort of a level understanding of what their role is and how that relates to the research project being done. In this case, it could be, to the program that they were providing input to. But I was able, based on my knowledge of what we wanted to accomplish with that group through the research project, I was able to develop like a 2-hour program, part of which was them getting to know each other and doing some talking. But anyway, I just wanted to offer that because I think those that are familiar with what you're going to be asking the patient and family groups to do can reasonably come up with some training and education to get them where they need to be.
Mm-hmm. Thanks, Debbie. Lawrence.
Yes, hi. So I'm just wondering if you could help me. I'm a family physician and I've been in practice over 43 years, and I'm working with families on so many levels, helping them grow, develop, be retrospective, have insight, finding people who need to go for therapy or have families where there are psychosocial dysfunction, and say they get admitted to the hospital. What is my relationship with this group? And is there any connection? Do you reach out to the primary care physicians, or do you go ahead and do all this and then the patients come back to where 90% of healthcare is given in the doctor's office, and I have to redo everything? Or how does this work?
Great question, and I'm not sure I'm the person to answer it. I'm wondering if anybody has a good response for that. Are you talking, Lawrence, about like patient advisors who are also patients? Is that what you were referring to? Oh,
It
yeah, I think
could
you're on.
be,
Yeah.
I'm sorry. It could be anybody who's in the group that you're talking about. There may be physicians. This can come up with a hospitalist who sets an agenda for a patient and then discharges, and some parts of that agenda are unrealistic, depending upon so many factors. So it could relate to anybody. A lot of these concepts, family-centered health, goes back 30, 40 years, Virginia Satir and many of the social workers who worked in family practice residencies. So family doctors have been dealing with these issues for so long, and we teach and we've learned to work with patients about a lot of the issues that you're talking about in the hospital. So I'm just wondering, how do we connect?
Yeah, I'm not sure this is going to answer the question, but what we have heard is that when patients are invited or requested or referred by their primary provider, they see that as a really good incentive to join an advisory or partner program. And I think what I'm hearing is, you're talking about there's some gaps and some needs that aren't being addressed, and they could be addressed by talking to other patients and families and seeing what they think. And I've got 2 hands up, so I'm gonna, does that answer the question, Lawrence? I'm not sure it does.
I appreciate your attempt, but no, not really. It doesn't.
Okay.
There's so
All right,
many.
well,
But this would be something to look into. I don't want to take up any more time, but this would be a good area to look into. It's very important. I'm teaching my family practice residents to do a lot of what you're talking about in the outpatient setting. And so it'd be interesting to see, maybe to include the departments of family medicine into the program that you're talking about.
Mm-hmm. Great. Yeah.
Thank you.
Yes, thank you. Karen. Oh, you're on mute, Karen.
Yes, thank you.
I do the same thing, so don't go
Yes.
back.
I'm from the Care Partner Project, which is a nonprofit, the carepartnerproject.org. where we offer dozens of free checklists that patients and families can download to help them know what to look for, what to say, what to do, and when to get a nurse. Usually, well, in hospital settings, emergency care, and so forth. And we offer this to hospitals so that they can, and we allowed them to brand them as their own. And we also encourage them to edit. We'll do the edits for them. And we've worked with the patient family advisory councils in this editing process. They get to see it, they get to comment. It's such a win-win, and it speaks to that goal of sort of the gold star of co-production. It's always easier to edit than it is to invent, right? And so through the editing process, there's a great deal of what we love about it is the focus on outcomes. So if they're looking at a fall prevention checklist where the checklist advises families that when they are with their loved ones in the hospital, make sure you point out everything on wheels and that you can't depend on it when you're on the move. It's relatable, and it's frankly embraceable. It's such a simple thing. And so we've just had such an amazing, and I just want to say there's that possibility of hitting the 2 marks, which is co-production and outcomes. So if anybody's interested, you can just go to our website, and it's right there in the nav bar.
Great. Thank you. And George, you might be the last one up for this one. Go for it.
Okay. Can you hear me okay?
Yes.
All right, great. Lawrence is so spot on. I am a retired family practitioner, pediatrician, healthcare administrator, master's level. When I stopped doing clinical in 2012, I went to patient navigation, basically what a good patient-centered, family-driven, educated person would do. Voice for the Voiceless is my nonprofit. Since we have stopped admitting our own patients in this country, we have lost the ability to have integrated care as family practitioners. The hospitalist specialty that came to be that admits our patients for us, it has ruined integration of healthcare because we do things. For my family or for clients I work with, I say, have you called the primary caregiver? For myself, when I was admitted with an emergency appendectomy, I said, my primary caregiver is give them a call, because they know the whole house. They know me from head to toe. And the hospital surgeons refuse to communicate with my primary caregiver. So absolutely, definitely a patient-centered, family-focused group such as these offices that opened up. If it's not in the SOP that with every client we have, you contact their primary care team and you get their input as to what we're working on, what's happening with them, then we're not doing it right. We might be doing a good job, but it's not the way it needs to be. Because Lawrence, you and I know, health starts in primary care and should circle back and end up back in primary care. It's the most efficient, cost-effective way to do medicine. And many of us, like myself, have left practice because I can't stand it the way it is, and I've gone to something else. So that's such an important statement. Thanks for bringing it up, Lawrence.
Yep. Thank you. Thanks, George. Barbara, you want to finish with any final thoughts before we move into the last few slides?
Yes, thank you so much for inviting me to talk about this. If you can just send me your information, email, I would love to be able to send you a survey on my dissertation, which, as you know, is on PFACs. And I encourage all of you to measure. And if you can't measure, contact me, and I will give you some recommendations as to how you can do that. And that's what I learned in my MBA course, and of course now I'm doing this, just researching PFACs, and also to promote what you do, spread it wide. And it doesn't have to be just an annual report. It can be after some great stuff that you've done that you let everybody know. Thank you again.
Great, thank you. Jasmine, do you want to finish us up?
Sure. Okay, so we have discussed several resources today, and we encourage you to take a look at them for more info. If you talked or chatted about a tool or a resource, which I saw lots of activity around that, and are willing to share, please feel free to send them our way. We can upload them to PFCC Connect. Okay, next slide. And we kindly ask that you complete our survey. We use the results to give us ideas on how to improve our conversations and also for future topics. You can use the link or the QR code to access that. And we'll also be posting that on the chat and in the follow-up email. Thank you. Let's see. And our next informal conversation will be scheduled sometime in July. The topic is to be determined. And the recording, the slides, and the chat log will be posted on PFCC Connect by early next week. You may email Marie directly with any tools, any resources or links that are relevant to this conversation. And as you probably know, you can always continue this discussion at PFCC Connect. Thanks.
Great. And I just want to say that as we started this conversation, we recognized and acknowledged our Pinwheel sponsors who support our ability to have PFCC Connect. But we have other levels of sponsorship. So if you are interested in becoming a Pinwheel sponsor, you can get more information on our website at this link, or Sherry Hayek, who's in charge of this program. So I want to thank everyone for taking the time to meet. It was very robust. We could do like 100 of these conversations on just this topic and not get through it all. But I appreciate all of you joining us today. Have a great rest of your day.